QT interval is the time from the start of the Q wave to the end of the T wave. It represents time taken for ventricular depolarization and repolarization, effectively the period of ventricular systole, from ventricular isovolumetric contraction to isovolumetric relaxation. The QT interval is usually measured in leads 2v5 or v6, and the lead with the longest measurement should be used. The end of T wave is defined by the maximum slope intercept method, where the intercept between the isoelectric line and the tangent drawn through the maximum down slope of the T wave. QT interval is measured from the start of QRS complex to the end of T wave. Maximum upslope of the T wave is used to estimate end of inverted T wave. Small U waves that are separated from the T wave should be excluded. Larger U waves, more than 1 mm, that are fused to the T wave should be included in the measurement. When notched T waves are present, the QT interval is measured from the beginning of the QRS complex to the intersection point between the isoelectric line and the tangent drawn from the maximum down slope of the second notch. The normal QT interval is controversial. In general, the normal QT interval is 400 to 440 milliseconds. Women have a longer QT interval than men. The QT interval is inversely proportional to heart rate. QT interval shortens at faster heart rates and lengthens at slower heart rates. Due to the effects of heart rate, the corrected QT interval, QTc, is frequently used. QTc is calculated using Bizet's formula, QT interval divided by squared root of R to R interval in seconds. The corrected QT interval estimates the QT interval at a standard heart rate of 60 beats per minute, and allows comparison of QT values over time at different heart rates, and improves detection of patients at increased risk of arrhythmias. QTc is considered prolonged if greater than 440 milliseconds in males, and 460 milliseconds in females. An abnormally prolonged QTc, more than 500 milliseconds, is associated with an increased risk of ventricular arrhythmias, especially torsades de pointes. A quick way to distinguish a prolonged QT interval is to examine where T wave ends, between the R to R interval. If the T wave ends past the halfway point of the RR interval, QTc is prolonged. Prolonged QT interval is observed in electrolyte abnormalities such as hypokalemia, hypomagnesemia, hypocalcemia, hypothermia, myocardial ischemia, increased intracranial pressure, and congenital long QT syndrome. Several medications can also cause prolonged QTc interval. Hypokalemia causes apparent QTc prolongation in the limb leads due to fusion of T wave and U wave. Prominent U waves can be observed in the precordial leads. Hypocalcemia typically prolongs the ST segment, but leaving the T wave unchanged. Severe hypothermia can cause marked QTc prolongation, often in association with bradyarrhythmias, especially slow atrial fibrillation, Osborn waves and shivering artifact. Myocardial ischemia tends to produce a modest increase in QTc, 450 to 500 milliseconds. A sudden rise in intracranial pressure may produce characteristic cerebral T waves, seen as widespread and deep T wave inversions, with a prolonged QTc. There are several congenital disorders of ion channels that produce a long QT syndrome and are associated with increased risk of torsades de pointes and sudden cardiac death. Romano-Ward syndrome is the most common form of congenital long QT syndrome. Romano-Ward syndrome affects only the electrical properties of the heart, and does not affect other parts of the body. Jervell and Lang-Nielsen syndrome is a rare form of long QT syndrome inherited in an autosomal recessive manner. They also have severe sensory neural deafness affecting both ears. QTc is abnormally short, if less than 350 milliseconds, seen in hypercalcemia, congenital short QT syndrome and digoxin effect. Hypercalcemia leads to shortening of the ST segment, and may be associated with the appearance of Osborn waves. Congenital short QT syndrome is an autosomal dominant inherited disorder of potassium channels, associated with an increased risk of paroxysmal atrial and ventricular fibrillation, and sudden cardiac death. Congenital short QT syndrome may be suggested by presence of lone atrial fibrillation in young adults, QTc less than 350 milliseconds with failure of the QT interval to increase when the heart rate slows, tall and peaked T waves. I hope you enjoy this video. Thank you for watching this video. Stay safe and healthy.